The S1Q3T3 pattern, McGinn-White sign, with initial description in Journal of American Medical Association in 1935, is the most famous ECG finding associated with a pulmonary embolism. But its clinical reputation often outpaces its actual diagnostic utility. While historically taught as the classic sign of pulmonary embolism, the clinical reality is that it is highly specific for acute right ventricular strain, but notoriously insensitive for pulmonary embolism itself. The S1Q3T3 pattern is not a direct electrical signature of a clot. Rather, it is a manifestation of acute cor pulmonale, sudden right heart overload. When a significant pulmonary embolus obstructs the pulmonary vasculature, right ventricular pressure spikes. As the RV acutely dilates against this sudden afterload, the heart anatomically rotates within the chest cavity. This physical rotation, combined with right-sided subendocardial ischemia, alters the electrical axis and produces the classic triad. S1, a prominent S wave in lead 1 signifying a rightward shift of the QRS axis. Q3, a new Q wave in lead 3 due to the altered depolarization vector. T3, an inverted T wave in lead 3 reflecting right ventricular repolarization abnormalities and ischemia. Because this pattern only reflects acute RV strain, it is not pathognomonic for a pulmonary embolism. It can also be seen in other conditions that cause sudden right-sided pressure overload, such as acute severe bronchospasm, tension pneumothorax, or acute exacerbations of COPD. Relying on the S1Q3T3 pattern to rule in or rule out a pulmonary embolism will lead to misdiagnosis, as it is only present in a minority of cases. Sinus tachycardia is present in 44 to 73%. It's the most common finding, though entirely non-specific. T inversion in V1 to V4 can be seen in 34 to 68%. Highly clinically relevant, correlates strongly with RV dysfunction severity. S1Q3T3 pattern is seen in about 15 to 25%. Specific for acute cor pulmonale but absent in the vast majority of pulmonary embolism. New RBBB seen in about 18%. Complete or incomplete, a reliable indicator of sudden right heart overload. T-wave inversions in the right precordial leads V1 to V4, often accompanied by inversions in the inferior leads, are actually more sensitive for RV strain in the setting of a pulmonary embolism than the S1Q3T3 pattern. Furthermore, these precordial inversions correlate much more closely with adverse clinical outcomes and echocardiographic evidence of RV dysfunction.